All right. Well, good afternoon, everybody. My name is Brian Lane, and I am the president and CEO for the Center for Health Affairs, as well as Champs Healthcare. And today we're blessed because we have one of our core strategic partners directly from Martti and UpHealth. And Martti by UpHealth is actually a team of innovators dedicated to building solutions that address the healthcare disparities impacting patients across the nation using telehealth. And Martti's language access solutions put certified and qualified medical interpreters within reach and one-touch simplicity in over 250 languages. Everybody just comprehend that for a second. 250 languages, 24/7, whether at the bedside, a mobile cart, or even throughout the overall health system or educational institution. And Martti integrates directly with your EHR, telehealth, programs and services. It increases your patient experiences from an investment standpoint, ensures language access anytime, anywhere. And I've also heard that they just published a textbook for remote telehealth language interpretation. We'll be asking the team about that in just a bit. But I want to turn it over first to John Lawlor, who is the regional sales director for the Eastern U.S. He's going to introduce his team to us today, and then we're going to dive into questions. And this is going to be a series, which is pretty exciting. So thank you all for joining. John?
Thank you, Brian. I really appreciate the kind introduction. Let me go ahead and introduce our industry experts, Danielle Meder and Tatiana Cestari. So I'm very excited to provide this webinar for all of our viewers. So let me give you a little bit of background on our members here. So Danielle Meder is a nationally certified ASL interpreter with over 15 years in VRS and video remote interpreting as an interpreter and operations leader. She's a licensed trainer of the Community Interpreter International with cross-cultural communications, and recently she co-authored and released a textbook on remote interpreting called The Remote Interpreter, as Brian mentioned. Danielle regularly writes, speaks, and trains interpreters and stakeholders in an effort to push for higher language access standards, as well as passionately advocates for best practices that support communicative autonomy for all. And then I'll move along to Tatiana, who is also one of our industry experts here. So Tatiana is a CHI Spanish healthcare interpreter and trainer, an instructor of pharmacology, and former research scientist in nicotinic receptor drug discovery. She's an avid advocate for best practices in research and language access, and is also a member of the board of directors and the Policy, Education, and Research Committee at the National Council on Interpreting in Healthcare. So she's been a really critical piece of the Martti team since 2012, and also a co-author of the Remote Interpreter, which she'll touch on a little bit more during this webinar. So I'll hand it back to you, Brian. Thank you very much for allowing me to introduce our experts.
Well, you've got a heck of a team here, John. So thank you for participating. And like I said, we deeply appreciate your strategic relationship and your effect in changing healthcare, either from a readmission standpoint, improving the age caps, helping the organizations out there increase just overall communications with their patients and their family members. And that's just it's been a necessary gap to address, and you've come to the table with a solution. With that, I think what we should probably do is make this first series, or I should say the first cluster around the series geared around the law and policy. Is everybody in agreement with that? Mm-hmm. So, it's the right thing and it's the law, right? So what does it mean first to provide language access, right? And that's a legal statement here to a healthcare setting.
Sure. So I can take that question first. And before we go too much further, thank you for the lovely introduction. It's super humbling to, are they talking about me? That's, it's always strange, but thank you for the honor of having us here. We really appreciate it and look forward to this whole series with you. When we talk about language access, I want to take it one step further back and really talk about what we're all trying to do when we communicate. And that is we all want to have communicative autonomy. And that means you can say what you want, when you want, how you want, regardless of language, culture, any identity label we could ever put on a person. We all want to have communicative autonomy. I have it right now. I am, of course, catering my conversation to this group here, the topic, and the audience. So in the healthcare space, you have language access when everyone has communicative autonomy. So that when a patient is in bed and the provider walks in the room and they don't share a language and a culture, but you're working through a language access solution, let's say, for example, an interpreter, that interpreter is working to support everyone's communicative autonomy. Because when you have communicative autonomy, you have effective communication, and then you actually have language access happening. And so if you don't think of language access as the box to check, but actually the framework around how we're communicating, then you can move into the next steps of what language actually looks like.
Got it. Well, that was great. Did either one of you want to add anything else to that?
I think she covered it all.
Okay. Well, let's get down to like the legal aspect of this. It's the right thing to do, and it's the law, but what are now some of the key aspects of the current federal regulations that all the healthcare entities must comply with? So if you can, just explain that federal landscape.
Sure.
All right, I'm going to try with this one. Of course, we can be talking about this for a long time, but I'm going to try to be brief. Yes, there are first, and I think for some people, this may be a surprise. There are many federal and also state regulations in place in the United States to make sure that any individual has that communicative autonomy, meaning if needed, there's language service available to them, okay? So in general terms, we have, or not in general terms, we do have, for example, Title VI of the Civil Rights Act of 1964. We also have Section 1557 of the Affordable Care Act, the Americans with Disabilities Act, the Executive Order. This one is 13166. And we have some state regulations as well, for example, in the state of Oregon and some other states. One thing that is common in these regulations is that language services need to be provided when needed, and the service needs to be of quality, meaning the person, if the solution to provide language access involves an interpreter, that interpreter needs to be qualified. It needs to have specific training and prove that the person is fluent, not only in English, but also in the other languages that the person is providing the service in. The individuals who are then translating, which is the written conversion of that message, they also need to be qualified. They also need to have specific training, and they need to make sure that they know also the specialized vocabulary in the field, because it's not the same when you're talking about healthcare versus the legal setting or educational setting. In addition to that, hospitals need to have, if they do have bilingual staff providing care directly in a language other than English, those individuals need to be qualified to do that. That means that they must prove that they are fluent in that non-English language to be able to communicate in that language. For example, I'm fluent in Spanish, but I can just come and say, oh yeah, I'm fluent in Spanish. And if that's the case and I'm providing language concordant care, so language directly in treatment directly in Spanish, my hospital needs to have proved that I'm indeed fluent in Spanish. Otherwise, it's a complaint issue, okay? It's a no-no. Like that, there are many other things included in these laws. There are also some standards out there to be able to provide culturally and linguistically appropriate patient-centered care that hospitals can utilize to build their language access plans, their policies and procedures, so that they can be in compliance. And not only they're following the law, but it's also the right thing to do, because in healthcare, you really need that communication to be effective, because that's one of the main tools to diagnose and treat a patient.
Our next question that I've got for this team is, what type of risks are institutions currently facing when not providing cultural and linguistic appropriate patient-centered care?
This is Tati's favorite.
Yes.
Oh, Tati, you want this one? All right.
Right now, well, there are many different types of risks. You can categorize them in many different ways, some of which are operational risks, financial risks, legal risks, compliance risks, reputational risks, my ultimate favorite. And all of these, and when I say all that, I mean it, is the same as not providing the care that you're supposed to provide. My favorite, as I said, was reputational risk, because if I'm a person who relies on an interpreter to talk to my doctor, let's say, I may go to hospital A versus hospital B because I've had a better experience in hospital A through their language service solutions versus hospital B. And that also affects leakage. So here comes the financial risk in addition to other things. And of course, you want to make sure you have great, effective communication and communicative autonomy so that there are no further consequences down the road in regards to patient outcomes. So,
can you give some examples of some of those other risks so that the audience can understand that? Are you thinking the same thing, Danielle?
Yes.
You are, aren't you? I can read it on your brain. That's good. That's good. We're in sync. We're in sync. I love it.
Do you want to go ahead, Danielle? Or?
No, go ahead. This is your favorite, but you said so many great things, and you give the tangible for reputational, but like, what are the other very common examples of the other areas of risk?
Yeah, when you don't provide language services, language access, you can be operating on the wrong limb. That's a big, think about when that happens in a hospital. Lawsuits, you can have your bottom line gets affected, your quality metrics, your CMS metrics get affected too, readmission rates, hospital-acquired conditions, all of that gets affected. Let me think. Legally, well, I just mentioned one. Compliance. This is part of, having those regulations out there. If you're not able to comply with them, there's a risk there as well. What else am I missing?
Even think about when a patient's discharged and they haven't been given the full scope of their discharge instructions. How many times do we get handed discharge instructions that are written in English and they're reviewed at a high level and they say, okay, go home and review them further, and if you have any additional questions? Well, what happens if it's a patient who comes into the hospital and not one of your top 10 or 15 languages, but they still need those discharge instructions, and then you wonder why they show up in the hospital again when they weren't able to follow through on the care plan that was agreed upon? Or we do follow-up surveys to patients to learn about their experience. What are the strategies in place to make sure you can follow up with your non-English speaking patient population to learn about their experience, so that you are sure that if someone says, hey, I need to go to a hospital, they tell them about your hospital or your clinic or your doctor, because these communities are very close and tight. And they really do share where they go, where they can feel the most understood and supported, where their communicative autonomy is respected.
Yeah. And it's interesting because let's say that specific case when somebody gets discharged and, they're sent home, and even with a translated document, okay, great. Now call us back if you have any questions or concerns. How am I going to call you back? Is this through an interpreter or not? You can check the results of your test via our patient platform. Let's call it that way. Is that also translated? Are the text messages to provide some sort of information to patients in their preferred language? And of course, we understand that sometimes it's not possible to provide effective communication to every single person but at least have some plans in place so that most individuals, if not all, can receive the care they need.
And I
Great
think
answers.
to help people really understand how traumatizing it can be to not have an interpreter available, there's a video that was put out, what is it now, 15 years ago, Tati, by the Texas Association of Healthcare Interpreters and Translators. And it was a video of a woman holding a baby going into an emergency room. She speaks English, but no one around her does. And actually the languages that they're speaking is like borrowed pieces from several languages. So not even a Spanish or a French or an Italian interpreter can understand it. And it's a visceral experience. And I think it's, and I would probably agree with Tati would agree that anyone working in healthcare should watch that 1 minute and 54-second video, because it really does show you how traumatizing and isolating and terrifying it can be to be in a healthcare environment and no one understands you. And I think it really leaves a mark on you, so that providing an interpreter or translation services becomes the priority, like washing your hands.
That's great. That's great. I appreciate that. I'm going to go to another question here with you. What's it like not to have equitable language access? And Danielle, you're kind of hitting upon it here. You know, how does that impact health equity for all these different communities who have different needs, right? Different languages, different interpretations. You know, how does it become more equitable, and how does it impact it?
Yeah, certainly. So we know, we're all familiar with social determinants of health, SDOHs. If we look at language access as the first SDOH to address and solve for, we have access to identifying all the other SDOHs that are impacting a patient's health, and that impacts their health equity, right? So we think about health literacy, we think about communicative autonomy, we think about hospital-acquired conditions, readmittance rates. All of that comes down to how are we communicating with that patient? And it's the easiest thing to solve for. It's having a great partner in your language solutions and your vendor solutions, having a well-developed language access plan, because not having that SDOH acknowledged and solved for regularly, routinely, every single time is going to impact all the other SDOHs, and at the end, their health and their health equity. And so we look at health equity through lots of different lenses, but sometimes and oftentimes we think of language access as the secondary thing, right? It's good enough, it's okay, but it's not, because it's our health. And so if we can put ourselves in the position of a patient who's at a disadvantage because they don't share the common language of the provider, then we understand why they keep showing up in the emergency room for the same issues. Well, what are we doing for follow-up care in their language? And not assuming that they can understand English good enough. That's never the case, right? I mean, think about how many times I've asked a provider to clarify something. Not often, right? Because if you speak English, I should understand what the provider's saying. Now put yourselves in the shoes of the patient who doesn't speak any English, or who speaks enough English and people get comfortable, right? Things take time. It takes time to coordinate an interpreter, to go through the interpreting process. But if we really value language as this portal into a patient's entire life, then health equity will improve for everybody.
That's a great point. Seriously, it's a home run point. And I deeply appreciate that. I want to ask, what common practices currently around language services are more dangerous or risky than a particular solution? And Danielle, you might have just hit upon it. You know, I mean, it sounds like there's a lot of Band-Aid, type solutions that are out there, that are currently being used, including, Google Translate, right? So right. I want to hear your thoughts on that.
So technology is here to stay, right? And as a on-site interpreter for years, a remote interpreter for years, technology can kind of be a little scary, but it's when it's used inappropriately. Google Translate at this current day and age and state is not a solution for us, right? Take any bilingual person. So Tati, for example, could go type in a very, a colloquial statement and have it translated, and it's just not appropriate, right? And it's good for basic interpretation stuff in a non-healthcare environment where life and death is not on the line, which can sound dramatic, but it can be. I believe the most dangerous places for any person who doesn't speak English in this country is in a courtroom and in a clinic, and Google Translate just doesn't belong there. So it is a tool, but it's not a tool in the healthcare space because one tiny misinterpretation can ruin the course of someone's life. And I know Tati mentioned having the wrong limb amputated, and I can imagine there's some people out there going, okay, right? But it is 2023, and in 2022, that happened to a deaf person whose interpreting service arrangement was not sufficient, and the wrong leg was amputated. And so when we talk about these kind of dramatic situations and that Google Translate can't be that dangerous, it can. I mean, we have the stories from the pandemic where people weren't providing interpreting services or doing the good enough or doing the Google Translates, or the unqualified bilingual who knows spring break Spanish when they go down to Mexico and they can have a nice time. They know enough to get through that experience, and all of a sudden they're being asked to interpret where, correct me if I'm wrong, intoxicated, the way it's pronounced in Spanish, is not intoxicated like you had a lot of fun and you drank too much, but it's actually poisoning, right?
Poisoned,
right? So the good enoughs and the Band-Aids and the deprioritization of language access as a medically critical, relevant thing to address out the gate. If we move that up the list, right, we want to know your allergies and everything else, but if we move that up the list at the same place as that of washing your hands before you walk into an operating room, and it's equal with that, I think we solve so many of those problems.
Yeah, I have some additional items that can be really risky. I've been accumulating items throughout the years, in addition to the ones Danielle mentioned. Also, not providing timely language services. And believe it or not, this happens a lot. And it's not, let's say that you do have a great language access plan, policies and procedures in place in your hospital, in your facility, but here comes the patient who needs language services, and now I'm the frontline staff figuring out how to bring an interpreter in, whether it's remote or on-site. How do I access the interpreter? How do I call? Who do I call? What button should I push? That is, it's actually part of the law. Every person providing helping others access to have access to language services must be trained and be able to access those services in a timely manner. So I've seen that practice throughout the country. Also, which also ties, it goes together with lack of training. Not only training on how to push a button, because I think many solutions now are very easy to navigate, but it's why we provide language services. Why is it important to do it the same way? Why is it important to wash your hands? Which has become a default thing. We don't even think about it. We just do it, right? I also have calling this other person who has a different role in the hospital to interpret for me. Whether it is a nurse, another doctor, a janitor, a social worker, that's their role. If you want them or you need them to interpret for you, then make sure you qualify them, you train them as interpreters so that they can serve that way. And of course, that has other operational things to consider, but at least they have to be qualified to do that. And I have a long list of different risky practices, but let's keep it at that.
We can't have a level of willful incompetence. I didn't know how to call an interpreter. I didn't know who to go to. That in a healthcare space, willful incompetence or playing the I didn't know card just can't work, because again, that's patient safety, patient risk, and their communicative autonomy on the line.
Yeah.
That's
and
great.
Even in section 1557 of the Affordable Care Act, that piece is there.
Excellent. Well, this wraps our first session pertaining to our series. I want to thank all three of you for coming online and participating and providing some background regarding compliance, the law, some of the core issues that hospitals and healthcare providers are currently facing pertaining to language services. And I really want to give you guys a huge amount of gratitude on the openness and the candor. So thank you for that.
Thank you for having us. We feel really honored to be able to share our experience and our knowledge, because in the end, it's all about patients, right? And their ability to get the healthcare they need. So thanks for giving us a platform and a soapbox and a megaphone.
Absolutely. Yes. We appreciate it.
Excellent. Excellent.